She is a resident of Mumbai and presented with chief complaint of lump in the right breast since 6 months. She was apparently alright 6 months back when she noticed incidentally a lump in the right breast. She described it as initially she noticed 2 by 2 centimeter and progressed to the present size of about 5 centimeter. Lump was not associated with pain, nipple discharge, or any other skin changes. There is no history of fever, trauma. There is no history of swelling in the armpit or contralateral breast. There is no history of weight loss, cough, chest pain, breathlessness, or hemoptysis. There is no history of back pain, bone pain, abdominal pain, or yellowish discoloration of the eyes or skin. There is no history of headache or convulsions. She is a premenopausal lady with regular cycles of 30 days with average flow of 4 days. She had attended her menarche at age of 12 years. She married at 24 years and given birth to the first child at 26 years. She had one daughter, 11 years, and she had breastfed for 1 year. Her obstetric history is P1, L1, A0, and delivery was by cesarean section. There is no history of use of hormonal pills. She don't have any comorbidities. There is no history of exposure to the radiation, or there is no history of connective tissue disorders. There is no history of lump in the ipsilateral or contralateral breast. She's having mixed diet, normal appetite, bowel bladder habits are normal, and she's not addicted to the alcohol or smoking. In family history, she don't have any significant family history for breast, ovarian, pancreatic, or colonic or prostatic cancer in the family. Sir, you want me to summarize the history, sir?
Summarize the history.
Sir, my patient is 37-year lady, premenopausal lady, presented with painless lump in the right breast for 6 months, sir, without any association of nipple discharge or no significant family history.
Okay, so first point, Ashish, is that your history was fine, but I would suggest that you straightway talk that there is no history suggestive of metastasis. I mean, in an undergraduate level, it makes sense that you go on telling that there is no history of cough, there is no history of bone pain, etc. But at your level, it's accepted there is no history suggestive of metastasis. Okay?
Okay, sir.
Apart from that, we have discussed history in the EBC class, and so I don't think we should be continuing with that. You can proceed with the general survey and the systemic examination.
Yes, sir. So, with due consent and in presence of female attendant, patient was examined. In general examination, she was conscious oriented, well fit. ECOG performance score was 1. Her BMI is 26 kilogram per meter square. She's febrile, pulse was 82 per minute, BP was 126 by 78 mm of H in right arm supine position. There was no pallor, icterus, clubbing lymphadenopathy, cyanosis, or generalized lymphadenopathy. Local regional lymphadenopathy I will cover in local examination. In systemic examination, there was no abnormality found. Respiratory system, bilateral air entry was equal on both sides with no added sounds. Per abdominal examination, there was no organomegaly or ascites. Per rectal or per vaginal examination was also normal finding. Cardiovascular system was next to heard, and central nervous system and musculoskeletal examination was also normal. Coming to the local examination, breast examination with inspection was started with the arm by side, arm raised above the head, hands placed on the hips and in bending forward. Ptosis of grade 1 was noted and breast size was 34C. In inspection, arm by side, there was right side nipple was deviated to the laterally and inferiorly compared to the contralateral breast. Right breast was showing fullness in the upper outer quadrant and also in the lower inner quadrant. There was powder orange appearance noted on lower outer and lower inner quadrants. There was no erythema, skin nodules, or ulcerations. When patient was asked to raise the arms, there was no apparent dimpling or tethering of the skin. There was no changes noted when hands were placed on the hip, and on bending forward, both breasts fall equally. There is no nipple or areolar retraction. There were no cracks, fissures, or eczematous changes in the perioral region. There was no limb edema. No fullness was noted in axilla or supraclavicular fossas. Palpation was done in supine, sitting, and semi-recumbent position. Left breast was soft. There was no palpable lumps. Left axilla was not showing any palpable lymphadenopathy. Right breast, it was non-tender, no rise in temperature noted. A single hard lump, 6 by 5 by 5 centimeter, with uneven surface and irregular margins, palpated in the right breast lower outer quadrant, and it was extending partially into the lower inner and upper outer quadrants. Skin overlying lump is edematous. No, the skin was not pinchable, and both the orange changes have been noted. The lump has restricted mobility in the breast chiasma, but freely mobile over pectoralis fascia, which was demonstrated by pressing the hands on the hip. On axillary palpation, there was
little louder.
Yes. On
Please,
axilla, on palpation of the right axilla, 3 by 3 centimeter mass was noted. It was non-tender, hard, matted, behind the anterior axillary fold. No brachial, subscapular, central, or apical group of lymph nodes palpable. Skin of the axilla is normal. No supraclavicular lymph nodes palpable on both sides. To summarize, sir, my patient, 37-year-old premenopausal lady, presented with painless progressive lump in right breast for 6 months. Right breast was showing both orange skin changes with underlying 6 by 5 centimeter hard non-tender lump without chest wall fixity, and the matted mass was noted in 3 by 3 centimeter right axilla. Sir,
yeah. Vijaykumar sir, would you like to ask question first? Then I would follow.
No, you start because I had difficulty in joining today. In the,
okay.
Net problem. You start.
Okay. Thank you, sir. Now, Ashish, on inspection, you told that this lady has got orange. Now, do you think this is an inflammatory cancer?
Sir, orange appearance is noted in less than 1/3 of the area, and there was no associated erythema. So, inflammatory carcinoma by clinical diagnosis is not present, sir.
Okay, and there is a well-defined lump as well, isn't it?
Yes, sir. Well-defined lump is present.
So, in a classical inflammatory carcinoma, what are the criteria?
Sir, orange appearance more than 1/3 area with erythema, and most of the times the lump is not palpable, and the diffuse enlargement of the breast is present.
And onset and rapid progression. Okay.
Yes. Yes.
Now, what do you understand on inspection or that there is involvement of skin?
Sir,
what are the criteria to tell that there is involvement of the skin?
Sir, skin involvement on inspection can be noted with dimpling or puckering of the skin may be evident. And
dimpling is called as skin. Excuse me. Hello.
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, dimpling, you will call it as skin involvement.
No, sir. Sorry, sir. Skin involvement.
No, the question was straight. No. When will you call skin involvement? What are the signs as per the science, if you want to say that? And then tell as per TNM, when will you call the skin is involved? That's all. 1, 2, 3, 4. Plus.
Yes. So, skin involvement, we will say it clinically involved when there will be ulceration or nodules, skin nodules seen. And when there is a puckering or dimpling, then we will suspect it, but we have to do a palpatory examination and confirm it. Both orange edematous skin is also suggestive of the skin involvement.
But don't, as sir rightly told, don't confuse, because this is the area of confusion, you should not be uttering, dimpling, or puckering a skin involvement right at the beginning. So ulceration, cancer includes your nodules, satellite nodules, and poderonge. These are the features to tell that this is skin involvement. Now, suppose in this lady, you, or in, for that matter, in any other lady, if you find that there is excoriation of the nipple areola complex, okay? So would that mean that it is a skin involvement, and what would be the impact of TNM in this particular patient?
Sir, skin excoriation will
Not
indicate...
skin excoriation, excoriation of the nipple and the areola.
Yes, sir. Nipple areola excoriation will point towards Pagets disease. So we have to rule out when bilaterally present, then it will be eczematous. But most of the times in unilateral findings, it is most likely a Pagets disease. So
what would be the TNM? What would be the TNM? Would you straightforward call it a T4B disease?
Yes, sir. The skin excoriation will contribute to the ulceration. And, it will be then T4B, sir.
Are you sure, Ashish? Now,
sir,
isolated Pagets without any lump, what would be the TNM? Can you
sir,
read
it will be T0, sir, if lump is not present. TX.
No, it's not
No,
TX.
no.
What is
it? Is not TX. It's not T0 because there is no lump. The Pagets presentation can be just a nipple areola excoriation, is it not so? And once it is the Pagets disease there, what you have to check is what when you have to suspect with lump or without lump. He is specifically telling there is no lump. Now what is the stage? Pagets without lump is considered as what? Where do you fit that in?
Sir, I'm not sure, sir. It's skin involvement. I feel it is T4B.
No, because the problem here is probably you are still lurking on this case with the 6 into 5 centimeter, etc. That was not the question asked by him. He says, when there is an excoriation of the nipple areola with lump, without lump, and you have suspected Pagets disease correctly. Now we tell again, I have given a clue. With lump, without lump, Pagets disease. Tell me what is the type. Sorry, stage.
Sir, no, I don't remember, sir.
Pardon me?
Sir, I don't remember, sir, Pagets disease lump.
Pagets is considered as what, at least you tell me? Forget lump, no lump.
Sir, it is considered as malignancy, sir.
Is it pre-invasive or invasive here?
Pre-invasive, sir.
If it is pre-invasive, then what will be the staging? Yes, sir, right?
Yes, sir. Tumor in situ. TIS.
Exactly. So read the TNM and root T1. Then you will find what exactly is Pagets. So Pagets does not without lump. I mean with lump, excoriation, everything might change. But without a lump, isolated suspected Pagets is TIS. Okay?
Yes.
Okay. Sir, you please.
No, Karyan. Now you have come to this. This is a common presentation in our country, even today, in a lot, particularly public settings. In that case, this issue should be very clear. You have made a diagnosis of T4B because of the purity orange, etc. And now there is a node in the matted node fixed to each other, so you are calling it as N2. Now, this is the clinical diagnosis. Kindly tell how do you proceed?
Sir, I would like to do bilateral mammography, breast mammography, and then core biopsy of the lump for tissue diagnosis.
Okay.
And then for staging workup, I would like to do, if available, PET scan, or then CCT. If PET scan is not available, then CCT, abdomen pelvis with thorax and bone scans.
Number one, Ashish.
I am confused now. I am really confused.
Yeah.
Tell me to do? This is the presentation is over. The patient is in front of you. Tell me what will you do? 1, 2, 3, 4. Tell me.
Sir, I will first do bilateral breast mammography, and then.
Okay. Now question number 1.
Yes.
Why do you want to do a mammogram of a patient who has got a T4B? What is working in your mind, T4B and 2?
Sir, for contralateral breast assessment to rule out the synchronous malignancy in left breast, we'll do mammogram.
What are the other reasons why you want the contralateral breast? What about this breast?
Sir, in this breast, if you are contemplating the breast conservation surgery, then to rule out the multifocal disease, sir.
Multifocal or multicentric? Anyway.
Multicentric involvement, sir.
Are you not going to confirm your diagnosis also, your clinical diagnosis by a mammogram?
Yes, sir. Mammogram will give.
Point number 1, Ashish, is, sir, once I have clinically suspected, I go forward with a mammogram plus an ultrasound. Do not throw away ultrasound. Ultrasound does have a role in these all patients. So a mammogram with an ultrasound, number 1 point is to confirm my diagnosis. Number 2 is to look at the centricity of the lesion or focality of the lesion. Number 3 is to assess the size of a locally advanced breast cancer. And number 4 is the opposite breast. Get my point?
Yes.
What is the reason why you would try to assess the size of the lesion in such a particular patient?
Sir, size will point towards the locally advanced disease, and we will also get idea about breast and tumor ratio.
But far more importantly, what does it?
Sorry, what will you plan for this case? I'm giving a clue. What will you plan for this case? Treatment. Suppose it is the same after workup. What will you plan?
Sir, I will plan for neoadjuvant chemotherapy and then surgery depending on the response and depending on the receptor status.
No. How will you assess the response?
So response assessment will be a clinical examination after or before every chemotherapy cycle and by ultrasonography or mammography.
Now you have answered this question, right? I will not answer this question now.
Yeah. So once again, we are asking the same question. What is the importance of understanding the size of the lesion before you start any form of treatment, say neoadjuvant systemic therapy?
Yes, sir. We will document the size and then compare on the successive radiological examination.
Okay.
Yes.
And apart from how you have shown that there is a metastatic lesion, possibly a metastatic lesion. How would a metastatic lesion look like in ultrasound in such patients?
Sir, metastatic lesion in the axilla or any other areas?
Axilla.
Sir, in axilla, the node will be showing loss of fatty hilum and thickening of the cortex. The size will be enlarged. It will be more than 1 centimeter. Sometimes there will be a central necrosis present, which is showing hypoechoic, and the shape of the node will be rounded. Normally, it is oval shape.
And there is loss of fatty hilum.
Yes, loss of fatty hilums.
Okay. Now remember, Ashish, what happens is that if this is the node, all the entry points are through the cortex. So first, there will be effacement of the cortex with cortical eccentricity. Then the metastatic cells are going to go inside the medulla. And the third thing will be blockade of the hilum. So there is effacement of hilum, and then the shape changes from a bean shape to a round shape. Then periadenitis features might also come over. Okay?
Yes.
So number 1 is a mammogram with an ultrasound. Number 2, what is the next investigation?
Sir, no, core biopsy, sir, of right breast lump.
Okay, are you going to go for a blind core biopsy? I mean, just on palpation, or you are going to go for ultrasound guided?
Sir, ultrasound guided preferably will do core needle biopsy of the right breast lump.
Routinely, or actually you might actually think in terms of selecting in some patients under ultrasound guidance?
Sir, if the facility is not easily available, then we can directly do a core biopsy by palpatory method. But it is not recommended as there is chance of geographical miss of the representative tumor.
So the better answer, Ashish, would be that I would initially go for an ultrasound or a mammogram, and in ultrasound, if I find that there is evidences of cystic degeneration, then you should not attempt a blind core. It has to be under ultrasound guidance. But if you find that the lesion is a solid one, then you can go for a core under palpation. And recently we did the ICMR national guideline, and we have strongly recommended that not routinely ultrasound guided core is required, but yes, if there are cystic degeneration, then it is mandatory to do under ultrasound guidance. Okay?
Yes.
So apart from a core biopsy that you are going to do for a histopathology, what other things you are going to do from the sample?
Sir, immunohistochemistry markers, sir, ERPR, HER2 status, and K67.
Now, looking at this patient who is 37 years, what ERPR heart new status is the most probable thing you are looking at?
Sir, in younger age, most probably, and looking at the aggressive presentation, it can be a triple negative breast cancer, sir.
Now, suppose this is a triple negative breast cancer. You told about the metastatic workup, isn't it?
Yes, sir.
So, you should not begin the other way around. You should not tell, as of now, the guidelines do not recommend to begin with PET-CT, and if facilities are not available, then you go down. The standard guideline is CT thorax, CT abdomen and pelvis, and bone scan. Okay?
Yes.
You can also choose to get a PET-CT scan, not the reverse way. Sir?
Yes.
Diptendra, I'm going to interfere here. What is the exact guideline or regarding PET-CT in CF breast? Because you said CF breast, I'm asking a different question. In this case, whether you do PET-CT or not, I'm asking, what is the role of PET-CT in CF breast?
Sir, PET-CT scan in NCCN, they are recommended as a 2B, and CCT abdomen pelvis also as 2B. But for symptomatic patient of chest metastasis, it is 2A recommendation in NCCN.
No, I have not understood now. 2A, 2B. What will you do? When will you do PET-CT? That's the question in CF breast. You want me to ask the other way? Will you do it for all cases? Will you do for early breast cancer? Will you do for metastatic? Will you do for locally advanced? Or one particular specific indications will you do? That is what I asked.
Yes, sir. Sir, locally advanced with large T4B, and if the nodes are N2, that is meted, and large axillary nodes also, then there is a high chance of distant metastasis. So we'll prefer PET scan as a single modality if passed.
You can help him, Dr. Sarkar.
Yeah. Now, as you rightly said, the criteria is all locally advanced breast cancer should have a metastatic screening done. One of the standard recommendation globally in most centers is CT thorax, abdomen and pelvis, and bone scan. You can also choose to go for a PET-CT scan. Clear?
Yes.
But what are the areas where you think that PET-CT scan can actually underdiagnose? Ashish?
Yes, sir. In PET scan can miss small lesions, small metastatic lesions less than 1 centimeter. In liver, with background metabolic activity, there is a high chance of missing liver metastasis. In brain also, brain metastasis, PET scan is not useful. In bone metastasis, if there is active marrow or previous fractures or something, then or pathology fractures are present, then it will be difficult to distinguish.
Yeah. But PET CT scan has the distinct advantage of locating marrow infiltration, which is one big advantage. I mean, bone is something where PET CT has got a high sensitivity, whereas in liver is something where lower sensitivity compared to a good, extremely good CT scan. Okay.
Yes.
Now let's move on. You told it can be a triple negative breast cancer. Now, if you consider it a triple negative breast cancer in 37 years of age, would you recommend, now it is an evolving paradigm shift, would you recommend any other investigation?
Yes, sir. Though there is negative family history, but the patient is 37 years, that is less than 45 years. With the NCCN criteria, we will recommend genetic counseling and genetic testing accordingly.
Very good. So you have completed the staging, and then you would proceed to manage this patient. So while you are going to do a core biopsy, can you consider anything else?
Sir, we will do coagulation profile, PTI, and
No, not coagulation profile. You are going for a core biopsy, and your plan is to go for neoadjuvant systemic therapy, and this is a triple negative breast cancer, suppose.
Yes, sir. So we will discuss with patient about the our probable plan of the management. If we are contemplating the breast conservation surgery, then we'll plan for the placement of the clips or marker in the breast lesion.
Now, realistically, in this particular patient who has got both a range, would you consider doing a breast conservation surgery?
No, sir. In the presence of the orange T4B lesion, we will not advise breast conservation surgery. It will be a modified radical mastectomy as advice.
Yeah. So, at your level, you should be answering like that. Sir, a marker placement is something which is strongly recommended. But in this particular patient, I found that the patient has got Poderons, and I'm not contemplating doing a breast conservation surgery. So I may not choose to put in a marker. Okay? Yes. But if you are contemplating BCS, a marker placement becomes mandatory. Where exactly will you place the marker? Within the lesion or in the periphery, multiple markers or a single marker?
Sir, single marker at the center, and if the after first neoadjuvant chemotherapy is the ideal time to place the marker, so that we can assess the response, whether it is centripetally shrinking or where the epicenter is moving. And then after first chemotherapy, we can decide the epicenter and place a single clip in the center of the lesions.
Okay. So suppose this is a triple negative breast cancer. What neoadjuvant systemic therapy would you prefer? Or in other words, how would your treatment vary depending on the molecular subtype or biological subtype?
Sir, in triple negative breast cancer, sir, there is a chemotherapy, standard chemotherapy as AC adriamycin cyclophosphamide 4 cycles, followed by 4 cycles of paclitaxel. Sir, if the receptor status are varying, if HER2 status is positive, then we can add anti-HER2 therapy, that is trastuzumab, or in like this high burden nodal disease, we can consider pertuzumab also, anti-HER2 therapy. And if hormonal status is positive and the HER2 status is negative, that is ERPR positive and HER2 negative, then we have to consider neoadjuvant hormonal or chemotherapy. But chemotherapy will be preferred to.
Ashish?
Yes, sir.
Hormonal or chemo? in this
Sir,
particular patient?
sir, this tumor is very large and high axillary tumor burden also. So we'll prefer chemotherapy as there is more chance of shrinkage, and we want to assess a response as early as possible, as this tumor may progress. And ERPR hormonal therapy takes time, about 3 to 6 months at least we have to give.
Now, I'm going to interfere here, Ashish.
Yes.
It's a 337-year-old, phase 3B. Let us imagine it is ERPR positive and L2 negative. You will contemplate, practically speaking, hormones?
No, sir. In this case, we will not prefer, sir. Neoadjuvant chemotherapy will be our choice, sir, though it is hormone positive. Because the response with the hormonal therapy is very delayed. And there is chance of progression also.
As sir has rightly told you, you are given him with the lead that suppose it's a 37 years lady, you do not contemplate routinely using a hormonal therapy, and you should not be answering that. The only scope of hormone therapy is if someone is more than 70 years of age. Okay? In young age, you'd always like to have a fast response, and the fastest way to get a response is to go for neoadjuvant systemic therapy. Okay? I mean chemotherapy.
Yes, sir. Neoadjuvant chemotherapy will be a choice.
Now, did you think that this was an operable LABC or an inoperable LABC to begin with?
Sir, it is locally advanced and operative upfront surgery is possible.
Possible. But again, no, I don't have any problem in undergoing a neoadjuvant systemic therapy. Now tell me, suppose this is a triple negative breast cancer, how many cycles of neoadjuvant systemic therapy will you use? For triple negative breast cancer, how many cycles will you use if it's a luminal cancer? And how many cycles will you use if it's an HER2 enriched cancer?
Sir, in triple negative, we do 4 cycles of the adriamycin cyclophosphamide. We'll assess the response after every cycle, and depending on response, we'll take decision. In HER2 positive, sir, we will use adriamycin cyclophosphamide, or there is second option as trastuzumab use with paclitaxel as trastuzumab as 10 cycles before surgery and 7 cycles after the surgery as adjuvant. If we are adding trastuzumab preoperatively.
And luminal cancers?
So in luminal cancers, we'll start with adriamycin cyclophosphamide 4 cycles, and depending on the response, we'll take decision on completing before surgery all cycles or after.
Okay, now Ashish, let it be very clear that if it is a triple negative breast cancer, use all your cycles before surgery. Okay, no confusions on that.
Yes.
In a luminal cancer, you operate once it is operable. So after 3 to 4 cycles, if you find that it's comfortably operable, then you can go ahead with surgery. But even if it's comfortably operable up to 3 to 4 cycles in a TNBC, you would still continue with a neoadjuvant systemic therapy. There is a robust evidence to suggest that if there is a complete pathological response in TNBC or in HER2 enriched cancer, that is a good prognostic marker. Okay?
Yes.
Now, HER2 dual blockade or single blockade, HER2 enriched cancers?
Sir, recent trials, phase 2 trials have suggested pertuzumab and trastuzumab use will produce more likely pathological complete response. But there is no survival advantage.
It's not a phase 2 trial, my dear. It's a recommendation. Of course, economy is an issue, but it's not in phase 2 trial anymore. It's not even recent. It's clear cut that dual blockade is better than single blockade in HER2 enriched cancer. Cost is definitely an issue with that. And again, try to use as many of them preoperatively to achieve complete pathological response. Okay?
Yes.
Now, suppose there is no, there is residual disease after you have used dual blockade. Okay? So,
Yes,
what
sir.
would you do after that? Would you change the regime? It's still operable. Would you change the regime or you continue with the regime?
Sir, after surgery, if there is no pathological complete response, then we will change the regimen, sir.
What regime you will change to?
Sir, TDM1, sir, added transducer.
Yeah. So that's the Catherine trial which had come up, which conclusively shows that if there is residual disease, you change to TDM1.
Yes.
Okay. Now, you have used and you have got an adequate response with your adjuvant systemic therapy. Now, and there is also remission in the axilla. You are not able to find anything in the axilla. Now, what is your surgical treatment in this patient?
Sir, as to start with, it was matted node, which is showing high tumor burden, axillary nodal burden. So we will do a complete axillary lymph node dissection, level 1 and 2. And if the nodes intraoperatively are not found enlarged or there is low burden, then we will not do level 3. But if the node is present, then we will do complete level 1 to 3 lymph node dissection.
So axillary lymph node dissection, whatever form you choose, it's up to you. Which are the subset of patients in whom you might consider sentinel lymph node biopsy or some other form of treatment in locally advanced breast cancer?
Sir, in locally advanced breast cancer with single node less than 3 centimeter will be considered as we can consider as to put a clip or mark the node after proving the FNAC positivity. Then we can do a sentinel lymph node biopsy after neoadjuvant chemotherapy.
What tool you use for sentinel lymph node biopsy in such patients?
Sir, dual dye technique, sir, technetium 99 sulfur colloid dye and methylene blue or isosulfan blue for sentinel lymph node biopsy. And that
do you people do it regularly in your setting?
Sir, no, sir. We don't do marking of the node or tag lymph node.
Pardon me. Talk a little louder.
Sir, we don't clip axillary lymph nodes and do sentinel lymph node biopsy as of now in locally advanced breast cancers.
No. Fine. That I didn't ask. Don't worry about LMBC. Do you do sentinel node biopsies as a regularly? I asked. Not for LMBC. In general, I'm asking.
Yes, sir. In early breast cancer, we do sentinel lymph node biopsy.
Fine. Tell me the technique now. What you follow?
Sir, we follow technetium 99 sulfur colloid dye technique and dual dye technique also with methylene blue. So before surgery, we inject technetium 99 dye in either nuclear medicine department or on table before after induction of the anesthesia. And methylene blue is also injected after induction of the anesthesia, and then after about waiting 15 minutes.
Where do you inject? How much do you inject?
We prefer retroviral injection of the methylene blue and technetium 99, and some consultants prefer peritumoral also in dermal injections of the technetium 99 dye.
I asked how much?
Sir, 2 to 3 cc of technetium 99 dye and methylene blue about 2 ml, sir, in retroviral position.
You can also choose to use ICG. Now that there is stronger recommendations coming up, you can also choose to use ICG for sentinel lymph node biopsy. The other question, Ashish, you told that you are going to put in a marker, a clip inside, isn't it? If you are planning to do a sentinel node biopsy after upfront upfront chemotherapy, but what is the role of putting in a marker? I mean, how will marker help you if you are planning a sentinel lymph node biopsy?
Sir, if the node is proven to be a metastatic node in axilla, then we have to plan the removal of the same node, whether it is responded or not. So, if it is responded, then it will be difficult to identify the same node. So we place the marker clip in the lymph node so that we can remove it, identify and remove it. Sir.
Now, Ashish, I think you have got a small bit of confusion about sentinel lymph node biopsy and targeted axillary dissection. They are two different things. Now, if you are contemplating doing a sentinel lymph node biopsy in a low volume axillary disease, then you don't put in a marker. You just go ahead, you give neoadjuvant systemic therapy, look at the downsizing that have taken place, and go ahead with sentinel lymph node biopsy. But that is strictly not for these high volume cases in axilla. But if you choose to have a targeted axillary dissection, which is different, in targeted axillary dissection, you put in a marker or an iodine seed or carbon tattooing, and then you take the clip node plus the tattooed node or the iodine seed node plus the sentinel lymph node. Then it becomes a bigger surgery because there is a 5 to 7% discordance between the clip node and the actual sentinel lymph node after a neoadjuvant systemic therapy. Did it make sense, Ashish?
Yes, sir. Yes, sir.
So they are two different entities. And don't try to confuse yourself that I will put in a clip, because putting in a clip doesn't make sense if you are planning for a sentinel lymph node biopsy. You are not going to identify the clip separately. Okay? That's targeted axillary dissection.
Yes.
Okay. So yes. You have done this, and what is your choice of surgery in this particular patient?
Sir, this patient, as we have planned before neoadjuvant chemotherapy as modified radical mastectomy, we will proceed with our preoperative plan.
Okay. Now, are you comfortable?
One second. Modified radical mastectomy in this case, fine. Axilla, because it is N2B, I'm asking you decided to go ahead. What type of axillary dissection you would like to do? We discussed about targeted, we discussed about sentinel node. What do you do when you say MRM? That means you're going to address the axilla routinely. So in that context, what I'm asking is, are you going to do 1, 2, 3 levels, or are you going to change it? Because the presentation is N2B, N2, sorry.
Yes, sir. We'll do level 1 and 2, and if intraoperatively you find enlarged nodes, then we'll go for level 3 lymph node dissections.
Right, proceed.
Sir, in level 1 and 2, if large node mass is felt, then there is high probability that level 3 is also metastasis is present. Or if there are more than 4 lymph nodes, there is also a high probability of level 3 lymph node involvement. So, if the large node or more than 4 lymph nodes at level 1 or 2 grossly enlarged seen, then we'll complete the level 3 axillary lymph node dissections.
Accepted.
Fine, next.
Ashish, now this is a 37 years lady, and of course she would not like to lose her breast. If she wants a breast reconstruction, what option are you going to offer to these patients? Is it to go for a primary reconstruction?
It's not advisable, sir. It is locally advanced breast cancer. We'll, if at all we are recommending, then we'll advise delayed reconstruction after completion of the all treatment.
Are you sure about that?
Yes, sir. In locally advanced tumors, there is a high chance of local recurrence. So the reconstruction is not immediately advised. It is preferred delayed reconstruction, sir.
I don't agree with you, Ashish. it has been found to go ahead with primary reconstruction safely in locally, unless you have something which is, it's fixed to the chest wall, etc. If you have an adequate response, you can always go ahead with primary reconstruction. Suppose I give you a lead that yes, I would prefer to go for a primary reconstruction in this patient. What would be your reconstruction modality of choice?
Sir, my preferred reconstruction will be microvascular free flap of DIP flap, that is deep inferior epigastric perforator plus flap. If the microvascular facility is not available, then transverse abdominis rectus flap, superior pedicle base.
Or an autologous LD, you can also think
autologous LD with silicone implant.
That's my question. Are you going to use silicone implant in this patient?
Sir, this patient will require radiation therapy post-operatively. So the silicone implants will have complications, more chance of complications like capsular contraction and difficulty in delivery of the radiation dose.
No, that is good. In simple thumb rule is when you are going to give post-op autologous, if it is otherwise you can think of silicone. Correct. Right.
That's the question we were asking you clearly. Okay, that yes. if you are contemplating, that sir told you that if you are contemplating giving radiation, do not think of putting in an implant.
Yes.
Okay. So, what would be, you have completed the surgery, now what is your next adjuvant planning?
Sir, depending on the receptor status, we'll decide the adjuvant therapy, or if we the cycles whether we had completed before the radiation, before the surgery, then we have to take a decision depending on the pathological response of the tumor. If there is it is triple negative breast cancer and we had given all the cycles before the surgery, then depending on the pathological complete response, if the pathological complete response is not present, then we'll add capecitabine for 6 months, about 1200 mg. And if it is HER2 positive and we had given neoadjuvant trastuzumab as 10 cycles, then we'll complete 1 year of trastuzumab therapy along with the remaining chemotherapy with paclitaxel also in adjuvant setting. If the ERPR status is positive, then after completion of chemotherapy, we'll add hormonal therapy. Most probably, hormonal therapy is preferred after completion of the radiation. So, on hormonal therapy, we'll add, as this is locally advanced and high risk, this is if hormone therapy, ERPR status is positive, then we'll also add ovarian suppression therapy, that is gorselin, along with tamoxifen.
You can also surgically choose to do bilateral salpingo-oophorectomy and then shift to aromatase inhibitors. Now, are you going to offer radiation to this patient?
Yes, sir. This patient is a candidate for radiation therapy as tumor is T4B and lymph nodes are also enlarged before surgery. So currently, depending on the pre-chemotherapy, the stage is considered for radiation therapy. So this high tumor burden, irrespective of the tumor response, we have to consider it as a candidate for radiation therapy in post-operative setting.
Thank you.
Correct. Correct answer. Correct.
Sir, I think we have nicely answered, Ashish. A big clap for you. I mean, you did very well throughout the performance. Let's take some questions. And if Dr. Somsekhar is there.
Yeah, there are a lot of questions both in panel chat and also in Q&A. I can read some of them. Can we do FNAC of the node and targeted clipping to plan post NACT? So I think Dipten already took it up in between couple of times.
Yeah.
Yes.
And sir, if there is a partial or complete response in this case, or say complete response, is there any role of PCS then?
The answer to the question is it is absolutely subjective. I mean, you have to look at it realistically. If it's a very small area of localized polyronge, then you might think of doing an extreme oncoplasty. But once you have skin involvement, I mean, going for breast conservation surgery should always be looked upon under good amount of scrutiny, because it is not always safe to do that.
Absolutely, absolutely. That is the answer students should say. As of today, in a skin involved T4B LABC, as a high level evidence, there is no role of breast conservation. However, case to case basis outside clinical trial or patient discussion can be taken. CSLNB after NACT, even when axilla completely responded, is it only for CN0 or even CN2 which has responded, we can do it? From Manish.
Oh, yeah. The answer to the question is, as I said, in a high volume axilla like this, when it was 3 centimeter matted, I would by no means consider doing an SLNB, whatever the response is, okay? Because it's a high volume disease. In a localized single node, as Ashish rightly pointed out, then yes, we can consider sentinel lymph node biopsy, but it has to be dual technique or a targeted axillary dissection. Dual technique will reduce the FNR rate to less than 10%, close to 8 to 9%, and targeted axillary dissection will reduce the FNR down to 6.1%. So TAD is the best, dual dye is the second best, but single dye techniques or single modality technique does not hold true, whatever it is. And in a high volume disease like this in the axilla, don't consider doing as SLNB.
Sir, also can you tell, before ovarian suppression, is it mandatory to confirm menopause biochemically and then go on to a surgical or medical, whichever?
Okay, so the question is now confirming that the patient has attained menopause does have a role in young age, but if you have done a surgical oophorectomy, I mean, you should not be considering once again to retest and then confirm. But in a perimenopausal age group, yes, in those circumstances, I would consider, but routinely testing the hormones doesn't make sense if you have done a good surgical oophorectomy and an aromatase inhibitor.
Yeah. So the corollary of that is like, just because a patient achieved amenorrhea because of the chemo and you're not sure she is postmenopausal, perimenopausal, don't treat it without confirmation, hormonal, biochemical confirmation. It makes sense also to put the patient on ovarian suppression if you are in doubt. Sir, how can we rule out granulomatous mastitis clinically? Zalak has
asked. Nobody on earth can ever confirm clinically on examination that it's a granulomatous mastitis. The only thing is that if it's a young lady within 2 years of lactation or a patient is diabetic and has got a prolonged history of recurrent pain, swelling with multiple sinuses, yes. But just at a glance, you cannot confirm. And granulomatous mastitis confirmation comes only after biopsy. Once you demonstrate there is non-caseating granuloma, if you demonstrate that there is a caseating granuloma, it will go under tuberculosis.
Next question is from Manish. Sir, if a patient is candidate for a post-op radiation, silicone implant, is it contraindication? Should not be used? Should we go to tissue expander?
No, this was answered actually, right?
Yeah.
The thumb rule is very simple. If you are thinking of giving post-op RT, it is better you don't use the silicone and use autologous tissue. This is the thumb rule. The reason is also well known. When you give post-op RT after the silicone or any other prosthetic work, the chances of the wound complications are more, capsule contracting. This has been the basis for what we are talking. But are there any studies, Dr. Sarkar?
Sir, as of now, for Indian patients, once you are doing this, I mean, you should not be offering radiation after. If you are you should not be offering a silicone implant, sir. If you are contemplating radiation.
Yeah, there is a study which is from UPMC Maggie Women Hospital, Pittsburgh, where they analyzed 230 patients of augmentation or on radiation being done, and they studied the effect of radiation on implant and effect of implant on radiation, and they analyzed that it is not absolute contraindication but a relative contraindication. Oncological outcome didn't alter in the modern era of radiation. However, roughly about 10 to 23% was the capsular contracture and implant related complications. So they concluded that while it is not an absolute contraindication, like see somebody had already a augmentation and a silicone, now they develop a CA breast, they don't want that to be removed and they still are amenable for breast conservation. Should we deny a breast conservation and radiation? Answer in that paper was no, it is not an absolute contraindication, but asymmetry of the breast on both sides and the loss of ptosis on that post RT and about 15 to 20% loss of implant has to be explained to patient. So this is the only paper that is available, and so while if you have a choice upfront, try not doing it as Vijaykumar sir told. But if somebody had it already and then they develop, case to case basis, take it, discussing with the patient while it is not regarded as not an absolute contraindication. There is next question, sir. Please explain the role of breast conservation surgery in case of a non-oncological excision done by a non-oncologist. Pradeep Kumar has asked it.
Oh, no, it's not a question of non-oncological surgeon or oncological surgeon. You are, I suppose what you are suggesting is somebody has done a sort of fibroadenoma excision and has come to you and possibly whether you should contemplate breast conservation. Yes, you have to select this on case-to-case basis. It's not that blindly, it depends on what is the diagnosis, what is the margin, what is the breast volume, and so many things, tumor breast ratio, and then you finally decide. But if it's a localized excision biopsy, then you can go for a wider cavity excision and shaving, and then go for a frozen section possibly to be very sure that you have taken out everything. Because in such cases, we don't want another re-excision to be done. You have to look into the pathology report to understand whether there was extratumoral DCIS or not. So there are so many factors before you jump on. It's not only the surgery factor.
Also, I think Diptendra, probably what Pradeep meant is there is a case of a probably say early breast cancer. A non-oncologist or a general surgeon who routinely may not be doing a breast cancer has done a non-oncological excision, maybe close margin, scar incision. So does that mean automatically mastectomy, or still a breast conservation can be salvaged in those patients if feasible?
Yes, it is feasible. If it is feasible, you should be offering breast conservation. You should be
especially with this era of oncoplasty, you can go ahead and do a local oncoplasty.
The only thing is, practically speaking, you will be worried how much he has dissected, how much we have to now go and remove. Those things will be an issue. So most of the time, we'll end up removing more than actually less. We'll actually remove more than what is required. But you cannot deny a patient of just because somebody has done a biopsy or excision biopsy or an attempted removal where cut margin has come positive. That's one thing you should take it. You cannot deny a person just on somebody has done a biopsy, and so you will have to go through mastectomy. That's not the way.
There is one more question from Santosh Kumar. Sir, is it mandatory to excise the scar in breast? So, scar has to be always included in excision.
So, at 9 o'clock, I have got this panel to moderate.
Done. This is the last question.
What was the question? I didn't.
Is removal of scar mandatory? See, suppose somebody has done
yes.
Scar.
The removal of the scar is mandatory. Whatever happens, the scar has to be revised and removed.
Done. There are so many questions that shows the popularity of both of you. But as I always say, all good things has to end. There are still about 100 questions. This is a topic when two great leaders are there, and especially fantastic teacher and examiners. This will go on for a day. But as I always say, our job is to stimulate and show direction. We can't spoon feed them. Now that they know so many points are there which needs to be read, they need to go back, read. We'll wait for some other class, some other forum. So thank you very much, Professor Vijaykumar sir and Diptendra for fantastic. And Ashish, you did outstandingly well. Superb. Very good. Keep it up.
Superb. Well done, Ashish.
Thank you. Over to
Thank you very much. Thank you very much, Dr. Diptendra. Some problem in joining because I was traveling, so I couldn't join. People are not able to see my face also.
Yes, sir.
Because of the internet connectivity. But I'm happy that I could join and I could. Thank you very much.
Thank you very much, sir. Thank you, sir.
Yeah, thank you very much, Dr. Ashish Bangar, for the presentation, and thank you very much, Professor Dr. Diptendra Sarkar, Professor Dr. M. Vijaykumar, and Professor Dr. Somashekar for joining us. And thank you, trainees and faculty members, for joining us.
Thank you.
Thank you.